My name is Russ Derry. I'm the Director of Education at Epilepsy Foundation of Michigan. And the topic today is Ask the Epileptologist. And we're very happy to have with us Dr. Aashit Shah, who's the Director of the Wayne State University Detroit Medical Center Comprehensive Epilepsy Program. And Dr. Shah, if you could just introduce yourself and talk a little bit about your clinical and research interests, and then also if you can explain exactly what an epileptologist is. I know there's not a single definition for it necessarily, but explain what that means to different people. So.
Sure, Russ. Good afternoon, everybody. I hope everybody's in the afternoon zone. And my name is Aashit Shah. I've been working in Detroit for now about 20 plus years, and in working in epilepsy most of my working adult life. So by training, I'm trained in neurology, followed by fellowship where I gained further expertise in epilepsy. And obviously I learned over the years about the field of epilepsy. And an epileptologist is someone who specializes in the field of epilepsy. Now, we may have a variety of different ways of epileptologists. There are people who are more clinically oriented, and there are people who are more, say, for example, neuroimaging, who look at more MRI aspect of people with epilepsy. Some are maybe more medication-oriented. So there are all kind of subspecialized epileptologists within the epileptologist group. But in general, epileptologists are the doctors who are involved in caring for patients with epilepsy. I spend most of my time in clinical settings, so I treat patients. We do a comprehensive evaluation of patients, whether they have epilepsy or not, what kind of epilepsy they have, how to best treat it, whether surgery is an option, what kind of surgery. And my research interests are also, again, mainly clinical aspect of things, electrophysiology, meaning the EEG aspect, and epilepsy surgery, as well as my other special interest is effect of epilepsy on young women or women issues related to women's health and childbearing age is another interest of mine.
Okay. One question I had, I guess I'll start the Q&A session off. I know in many cases epileptologists aren't seen by a patient until that patient has failed multiple medications, and often this may be years after they've had that initial diagnosis. Is there a case to be made for seeing an epileptologist sooner in the process? And if so, are most epileptologists willing to see people who are either newly diagnosed or maybe not yet diagnosed?
Yes, for a short answer, and the long answer is that is true that most patients, by the time they end up seeing an epileptologist, have been seeing other physician for many years beforehand. And they have diagnosed with epilepsy, and they have been tried on a variety of different medications, and nothing is working, and that's why they go and see an epileptologist. Now, there is more and more evidence that uncontrolled seizures may have other consequences on people's health, affects their memory, affects their, obviously, quality of life, and a variety of different medications have its own side effects. So current recommendation is that if somebody has been what we call medically intractable epilepsy, meaning no medications are not working, then they should be referred to epileptologist or a comprehensive epilepsy program, perhaps within a year or two of the diagnosis of epilepsy, just to get a comprehensive evaluation, get to the bottom of the diagnosis and see if they can benefit from surgery or not. And that is what the recommendation is made by American Academy of Neurology, and that is going to be slowly implemented and advertised to the neurologist as a group that they need to start referring this patient to a comprehensive epilepsy programs early into that illness.
Right. Right.
And the main reason behind that is that after somebody has failed 2 or 3 medications for epilepsy, further medical treatment may not be as fruitful. Chances of becoming seizure-free with further medication may be in small percentage, less than 5%, I would say.
So I just asked the first question. Let's open it up to the audience. Who else has a question? And again, I reemphasize that if we don't have any questions, we're not going to have much of a session. So please ask away.
I have a question about women's epilepsy that you were talking about.
Go ahead.
Okay.
I'm 25, and the neurologist said that I had severe migraines, and then he said, I can no longer treat you. It's your hormones. And my OBGYN said, no, it's not your hormones. And then I was on Topamax, and I had all the side effects of Topamax. So then they told me that I was in a state of psychosis. And then I went through 3 months of intensive therapy, and the psychiatrist had said, this isn't a this isn't a psychiatrist issue. You need to get tested. So do hormones play a factor in age? And I've lost 20 pounds in the last 4 months. So right now I'm just trying to kind of put all the pieces together.
So you don't have epilepsy. The diagnosis is migraine. Is that correct?
Migraine, and I'm going to an epileptic specialist tomorrow. So this is just kind of like a prep for me.
Okay. So the question is that whether do you have a seizures or not, and I can answer some general aspect of things regarding seizures and hormones. Obviously, I cannot comment about you in particular because I don't know all the information.
Okay.
But in general, migraine and epilepsy both can be affected by hormonal cycling in women, and so certain phases of cycle you may be more prone to suffer from seizures. That is called catamenial epilepsy, or basically it means it varies with the cycle. It doesn't have to be at the time of period. It could be in the middle of the cycle when ovulation happens. So it could be usually the second half of the cycle when seizures are more likely to occur. It's not necessarily a different type of epilepsy. It's just epilepsy could get worse around certain time of the cycle, meaning you are more prone to have seizures. And there are ways to deal with it depending on the pattern, and sometimes certain medications can help. But I'm talking about epilepsy. Migraine is obviously a different issue, but it also can be affected by hormones.
Okay. Should I have a medical alert necklace?
That many people find that effective. Dr. Shah, is that something you recommend?
Right. The medical, those bracelet, the medical alert bracelet is quite useful because if you have a seizure out in the public and nobody from your family is around, and if you act different or you are passed out, at least people can see what is there and what kind of condition you have, and they know what may be going on. But at times I have seen that people get in trouble with law enforcement because they have a seizure out in a public area, and following seizure they are confused and they're acting strange, and they may get in a scuffle with somebody because somebody tries to do something to them, or they are just acting strange and somebody calls the cops, and cops try to talk to them. They are obviously confused, that person, and they get hurt because cops don't understand what is going on with them. They try to tackle it as like they are trying to somebody is dangerous, even though that person may not be dangerous. And having a bracelet in that situation, at least somebody can realize that this might be related to seizure, and give you a little breathing space or get appropriate medical attention.
Right. And
okay.
some people have now. There are many companies that will make pendants that you can wear that have a flash drive on it, so you can keep all of your medical records on that, so that you can have that with you all the time. So that's another option that some people use. Other questions?
Yes. This is Arthur Scott. Yes. I'm 61. Well, my question is, I've been having seizures since I was on. My question, I was wondering will all the seizures, will it affect my long-term, all the seizures I'm having, will it affect my long-term memory?
Seizures affect your memory. That is your question.
Yes.
There is some information available that people with seizures have trouble with memory. And that is maybe a two-edged sword. There is no type of seizure which is most common type in adult is called temporal lobe epilepsy. And temporal lobe is part of the brain which also controls the memory. So if you have a damage to that causing seizures, you may have the situation where it also affects your memory because of the underlying damage to the brain itself. It may not be the effect of seizure itself. On the other hand, seizures themselves can affect the function of the part of the brain which is involved with memory called hippocampus. Having ongoing seizures can affect your memory. So sometimes even in between seizures, what is going on in your brain with what we call spikes can also affect memory. So we don't understand the full relationship of that, but definitely ongoing seizures which are not controlled can affect your memory.
Art, were you asking specifically about long-term memory versus short-term memory?
Well, no, not short-term memory, long-term memory, because I started having seizures when I was 13, and I don't have a lot of seizures, but I have like one every 2 or 3 months usually, but sometimes they're more often, sometimes 3 or 4 months, but I have never gotten to the point of complete control. I don't have them that maybe one every 4 or 5 months or something, but I'm talking about the effect of them from when I was 13 to 61, and I was just trying to get the overall thing of if they're going to affect my. I know they can affect one short-term memory, but I was trying to figure out if they're going to affect my long-term memory. All this.
If you have enough trouble with the short-term memory, which is what the seizures affect, when you are making new memories. But if you have enough trouble with the ongoing short-term memory, it will ultimately affect your long-term memory also. But once you already have formed the long-term memory, like what we experienced you had when you were, say, 15, and you already remember it well, having seizure usually does not wipe out the old memory. It just interferes with the creation of new memory. But as you say that if you have seizures from 13 years to 61 years, all those years you may have trouble making new memories, then yes, your long-term memory is going to be also affected.
Okay. Other questions? Particularly anyone who hasn't asked a question yet?
I have one.
Okay.
Okay.
Kind of a comment. I don't even give it a comment. About 10 or 12 years ago, I was diagnosed with seizures, and that's because they did an EEG. But prior to that, people have always thought I was strange because I had these stare sessions. So my belief is that I've had seizures for a long time, and this was the first time that it was diagnosed. Mm-hmm. Stare seizures obviously aren't how do you want to say it? Aren't as dangerous to the person as a grand mal or something like that. But they're still frightening. They used to happen probably once a day for about 2 weeks, and then now it's down to once a month, which is very good for me. However, I can't drive because of this inability to just the ability to stare, for lack of a better word. What new techniques are available there, or what new meds are out or available, or since I know that's not probably one of the ones that people are really worried about that much, but obviously it stops me from driving and a couple other things.
Mm-hmm.
I guess my question
okay, go ahead. I'm sorry.
My question would be, is there anything new out there is there something, obviously it's probably something that doesn't warrant a vagus nerve stimulator or something like that, but still it has its annoyances, it has its nuisances, and it has its downsides. So what would you suggest? I've had a talk with my doctor, and he's more complacent, and I think I talked to Russ last week about it. He's very complacent about being treated now. It's like, okay, you go in and test for strokes. That's about what he tests for. So I was kind of trying to get into another program, and he had made some suggestions. But I guess my question is, other than that, and that was very good suggestions, what is available lately?
Okay. So first of all, what you are calling is staring seizures, which has been going on for a long time. There are a variety of different underlying cause for staring type of seizures.
Okay.
And depending on what kind of underlying type of epilepsy you have, you obviously have a different options available. There are certain type of epilepsy which, obviously the variety of different medication works. A certain type of epilepsy, maybe vagus nerve stimulator can be considered. So other type of epilepsy, if you were to say for coming from only one spot or one area in the brain, then you can even consider epilepsy surgery. A surgeon can go and remove the part of the brain where the seizures are coming from, and you can stop seizures completely.
Oh,
now,
okay.
So there are medical options, meaning different medication. There are options for vagus nerve stimulator and surgery, and they all obviously needs quite detailed evaluation and a lot of tests and other things to figure it out. Depending on what you have, to know what would be the best for you. Now, two things I want to comment on your experience is that I would not necessarily call staring seizures less dangerous. Obviously, grand mal seizures are much more dramatic, and you are more likely to get hurt because you fall down and stuff. Mm-hmm. But staring seizures, because you are not aware at the time what is going on, could be equally dangerous. I have seen people, having staring seizures while they're cooking and end up getting burned.
Yeah,
staring seizures. People spill a hot coffee and got a third-degree burn.
Yeah.
Somebody had a staring seizure in shower and got burned. They ended up falling on the stairs. So there are a variety of ways you can get hurt. So it is not that staring seizures are minor things and you shouldn't be taking them seriously. All seizures are major things, and you have to take them very seriously. So being complacent about it, something is not you should be accepting. You should be asking what else can be done. I'm not saying that there is always something more can be done and everybody's seizures go away. Mm-hmm. But you should be always keeping options open. There are new medications available, new treatment options available. And some of them maybe will work for someone like you. So I think you need to explore those things and not just accept that, okay, having one seizure a month is, that's good enough for you. That maybe, you can do even better than that. Maybe not, but at least you should look into that.
Because a lot of times I've been twice into the EEG monitoring, and nothing happens. Mm-hmm. And you think, well, maybe you're crazy. That doesn't really happen or anything like that. So it's very hard to...
I understand, and that is the problem we face every day with being a doctor treating seizures. Is people ask that, I come there and you nothing, you can't find nothing, but that is the nature of seizures, is they are unpredictable, and I cannot predict any better than you can when your next seizure is going to be. There are certain general rules, and there are some risks involved, but there is nobody can tell you that, okay, you are going to have seizures today or tomorrow.
No.
So that is where the problem. It's one of the problems.
Do seizures? A lot of people who have seizures, do they end up having a bad memory?
Yes, that is. A certain type of seizures are more likely to do that than others. We just talked a little bit briefly before this. There are two reasons, or three reasons could be the memory affected. One is that certain type of seizures, if it is coming from the temporal lobe, that may be effect of some injury to your temporal lobe, which affects your memory and causes seizures both. So, seizures itself is not causing memory, but whatever affected your temporal lobe, let's say you had a head injury which damaged your temporal lobe, so you have bad memory from that, and that also caused seizures, then you have seizures and memory problem both from head injury. Second thing is if you have ongoing seizures, it can interfere with the new memory formation, and that can affect your memory. And third way you can affect your memory would be because obviously you have seizures, you take medication for seizures. If your seizures are bad, you take higher dose, you have to take more than one medication. And all this medication work on your brain. That's how they work for seizures. And there are many unintended side effects from this medication and may affect your memory. So that may be other reason your memory can get affected.
Well, maybe from the medication, because my seizures are not temporal lobe, so they're from the part of my vision area of the brain.
But it may be starting in the vision area, but maybe going to the temporal lobe. So seizures are something which travels in the brain. It starts at one point because it is electrical activity, so it can go from like a wire, it conducts from one place to other. So a lot of time, even if it started in vision area, it may end up going to the temporal lobe and affecting that.
Oh, is it possible that it might not? Because the doctors have never told me that it does.
If you are losing awareness of your surrounding when you have seizures, then most likely your temporal lobe are getting involved. If you're pure vision involvement without you losing consciousness or awareness of surrounding, then probably only your vision cortex is affected. But if you are losing awareness what is going on around you at the time of seizures, then most likely your temporal lobe is getting involved.
Okay, so that can cause memory problems.
It can, plus I'm sure you are taking medication for seizures. That can also cause the problem.
Yes.
Right.
Okay.
And you also asked about what can be done, and can you improve your memory? And that's a difficult question too. There are some things that are, when there's structural damage to the brain, that you may not be able to improve the memory problems associated with that. But if, for instance, your memory problems are related to your seizures and it's preventing the formation of new memories, or if you're having these interictal spikes, basically this abnormal electrical activity between seizures, that can also affect your memory. And by improving your seizure control, you may then also reduce those effects on memory. But on the flip side, like we mentioned, if your medication is the side effects from the medication are causing the memory problems, you might be able to reduce those side effects by lowering your medications if your doctor, is willing to do that, and if that's something that can be safely done without causing additional seizures. So it's always trying to assess which of those factors is contributing most to your memory problems, and which of those can you adjust possibly or change, and which of those are probably not going to change. And in that case, you may need to think of ways to compensate for your memory problems rather than trying to improve your memory.
And there is something more regarding memory. Kim, and there are sort of a therapy that you can work with a neuropsychologist, techniques and stuff. It is not truly not changing, but using some techniques to improve what you need to do for your memory and how you remember better. And sometimes those things are very helpful, even though they may be very apparent after you learn about them, how to improve your memory. And I have found that certain patients of mine learning those techniques and stuff can actually benefit quite a bit from.
Where can I find out about that?
Well, actually, we are.
You can go.
In December, we're having
a
conference call on that called Assistive Technology for Cognition. So I'm going to be talking about different devices and technologies. Even something as simple as sticky notes is considered a technology, but there's other technologies that you can use to help as memory aids. So that's.
I know. I have a terrible memory problem.
Yeah.
I completely lost my memory when I acquired my seizure disorder because I have seizures on both sides of my brain. And I use a daily planner, and I write every single thing inside there.
Right.
That helps me wonderfully.
Okay. Well, I guess if I went online and I looked up the memory techniques. What did you call it again?
Memory improvement or cognitive.
Yeah, well, you can register for the Learn at Your conference call on December 5th on assistive technology for cognition. I'd be happy to give you additional resources on memory as well. And then what Dr. Shah was talking about, there's neuropsychologists and sometimes occupational therapists might do it as well. There's something called cognitive rehabilitation, which uses a different variety of techniques to help you compensate for your memory problems. And then sometimes there may be efforts to actually try and, through repeated exercises, to try and either prevent your memory problems from getting worse or even improve your memory function. So.
Yeah.
Right. There are a variety of different resources available. You can ask if you have an epilepsy specialist in a clinic, they may be able to provide you some information, and I'm sure Russ can also provide some information and resources how to go about these things.
Right. Yeah. So that's fine.
Yeah.
Other questions? Anyone who hasn't asked a question yet? I know we have several people on the line who have been listening, but anyone who hasn't asked a question yet who has a question?
The only question I have is the fact that a lot of us take more than one medication, because I know I take more than one medication because I have more than one type of seizure. And I'd like to know if it's just me or is there a lot of other people who take more than one medication?
If you talk about patients in general, all the patients who have seizures,
I know
about 50 to 60% of them can be controlled on medication. Vast majority of them with one medication.
With one medication.
That means vast majority of them. But that leaves another 40% or so are not controlled with one medication. Many of them are on more than one medication. At times that is useful, many times it is not. At times it is difficult for patients as well as doctors to withdraw medication when somebody is already having seizures.
Yes.
Say you are 3 different medications and you're still having seizures and you go to a doctor. You will be afraid of taking one of them away because you think that now you are still having seizures on 3 medications. If he gets down to 2, maybe you will have more seizures. That is not always true. You may be having as many seizures on 2 as you are having on 3, or you may be having as many on 1 as on 3. Just taking more medication doesn't always necessarily mean that your seizures are better controlled. So you always have to ask yourself, and your doctor has to do that too, is all this number of medication is truly working for you? Do you truly need all these 3 or 4 different medications? In my opinion, vast majority of the people who take 3 or 4 medications don't need 3 or 4 medications. They maybe do just as well from seizure point of view with 2 medications. That doesn't mean that their seizures are going to stop, but you are having seizures even while you are taking 3 or 4. Maybe at least you would have a little less side effects, and you would have to not swallow that many pills, and your seizures would be about the same. If there are other options, then again we talk about other options like vagal stimulator, different diet therapies, or some other strategic use of medication as needed basis, or some time of the your seizure cycle, or even epilepsy surgery. All those things can come into play at that point that what could be the best for you. So there are a lot of people who take more than one medication, but it is not necessary for most.
Okay.
I had a question, actually. How much, it's related to anti-epileptic medications, but how much do we know about their effect, particularly the older anti-epileptic medications? How much do we know about their effect on, or their long-term impact on vascular health? I've seen a few articles saying that certain medications can increase certain markers of vascular disease. And is that something that is accepted as a long-term consequence of being on medication for several years, or is the jury still out on that? And if it is accepted, is that something that patients should be screened for, Should they be screened for, particularly if they have other cardiovascular risk factors?
I know what you're talking about now. So like something like carbamazepine and things have been associated with the cholesterol abnormalities and things like that. But the jury is not out on that. I personally do not believe there's any clear evidence that taking this medication over a longer period of time increases your vascular risk.
Okay.
There are other health effects now, obviously. Phenytoin or dilanthane cause some part of the brain to atrophy. You may have more trouble walking, enzyme-inducing anti-epileptic medication like dilanthane, Tegretol, effects on the bone and the bone thinning, which is a much more real problem than a vascular problem risk is. So there are other consequences of long-term therapy, which are luckily not that major other than the bone health issue, which is obviously the issue.
What other, you had mentioned yoga and diet therapy, and I presume Reiki or something is involved in that too. What kind of diet therapy would you go on, or would you be some sort of elimination diet? Would you start off with something basic? How does that work?
Right, there is something called ketogenic diet, which is particularly used in children, very young children who have really bad epilepsy. Mm-hmm. In adult, this particular diet is very difficult to follow because it almost restricts carbohydrate completely, that you cannot have any carbohydrate. So basically you end up eating just fat and protein. And without any carbohydrate, meaning you cannot have any kind of flour or any kind of wheat flour or rice or anything sweet with sugar. Mm-hmm. Makes it extremely difficult. What can you eat, which is just fat and protein? I mean, you cannot have steak by itself all every day, or fish, without having a bread along with it, or no having any dessert or anything. Mm-hmm. So it becomes extremely difficult for adults to follow that diet over a longer period of time. And second thing is that if we eat that much of fat in our diet, is it good from our cholesterol point of view or a heart point of view? That is again a difficult situation in older individuals, adults basically, than compared to kids. In kids, you can basically control what you feed them, the babies we are talking about. So that is, still people do it, and it can be effective. People have tried to use similar diets, such as, say, modified Atkins diet, which is something similar where you restrict the carbohydrates. Now, jury is not out on that, is that whether it is truly effective or not. Ketogenic diet has been shown to be effective. Like modified Atkins diet and things like that, we don't know whether that would work or not. Now, yoga and stress reduction and all those things, again, there is no proven benefit of them for epilepsy particularly. But as many of you know, that stress and other environmental effects can cause seizures to get worse, or at least when you have seizures, it may bring out your seizures. Yes. So taking care of those aspects of your life with yoga or some other way of stress reduction, making your life much more regular, healthy eating, adequate amount of sleep and rest, avoid alcohol and other substances like that, clearly would help to reduce number of seizures you can get. So, in general, those things are not particularly effective on one-to-one, but in general, healthy lifestyle and those kind of regular exercise and other things have a lot of health benefit, including, I would assume, that it will benefit your seizures.
Okay, thank you.
I have a question.
Yep.
What is considered an accurate amount of sleep to have?
Right. It is very important. One of the two things which I always tell my patients is that when they say that what can cause their seizures, or what can bring out their seizures, what they can do to avoid having seizures. There are two things which is quite well known to what we call lower the seizure threshold, meaning it makes your brain more likely to have seizure at that, if it is in that situation. One is sleep deprivation, another one is alcohol, or those type of substance, illicit drugs like cocaine and things like that. So those two things in particular are very bad for seizures. So if you say don't have enough sleep, the next day you are much more likely to have seizures. So that is one thing, and I always tell my patients to keep their life much more regular, have enough number of sleep hours, and not to consume alcohol or drugs.
Right, and the number of sleep hours that's right for each individual.
I mean, it is known.
There's no, number that's perfect for everyone, but usually, between 7 and 8 hours is required for most people.
I always tell people that they need at least 8 hours of sleep if they have seizures.
Right.
I'm sure some people can get away with 7 or 6, but I would usually recommend at least 8 hours. And second thing I recommend is that it's not 8 hours today and next 24 hours you stay awake and then again take 12 hours of sleep. That is not what I'm talking about. Right. It's not 8 hours of average. It is that you need regular 8 hours of sleep on a daily basis.
Exactly. Yeah, and you also need to consider sleep quality too. If you're getting that total number of hours, but you're waking up a lot, or you're not getting reaching all of the necessary sleep stages, because you may have a sleep disorder or something that can affect your seizure frequency as well.
Right. No, somebody has some problem with sleep apnea. That obviously does. It is considered one of the risk factors for stroke as well as bad seizures. Taking care of your sleep apnea may actually help seizures.
Mm-hmm. Okay. Other questions?
I have another one.
Go ahead.
Okay.
You had mentioned somewhere before that the temporal lobe was involved. The business when you have a seizure, you can't remember anything. Is that typically what temporal lobe means? Because I had a breakthrough seizure, and I did not know where I was for probably a good 24 hours. Is that typical, or?
24 hours is not typical. Usually this confusional state lasts for a short period of time. We are talking about 10, 20, 30 minutes type of situation. Mm-hmm. In some situation, it may last a little longer. But occasionally people would have that confusion or effect on their memory lasts for longer. In most situations, that happens if you have more than one seizure or you have a long seizure, meaning your seizure itself was several minutes or 5-10 minutes, that effect may be much longer. Or you had several seizures within a short time, like you had a cluster of 3-4 seizures within 2 hours or something. Then you are much more likely to suffer from those kind of confusion afterwards.
Okay, so the breakthrough with unconsciousness, maybe it's just for the first part of it, but then eventually when we start asking you questions, you can give answers to questions, but they're they're more like a dementia answer than anything else. That's normal, or that's not normal?
That is also normal. That is the way the brain recovers, that for a while you're completely not functioning. That part of the brain, then you recover partly, so it can work to some degree, but not fully, and then gradually it gets back to your normal. So that process is not exactly same in everybody, or it may not be same in even same person for each seizure, because every seizure may not be necessarily exactly same from one time to the next.
Okay, thank you.
Mm-hmm.
Other questions?
Hi, this is Judy Aaron. You spoke briefly about osteoporosis with certain drugs. Could you expand on that a little bit more?
Sure. What we call enzyme-inducing drugs, so those are the drugs which are metabolized through liver, and it mainly involves the old generation of seizure medications such as dalantine or phenytoin, tegretol, primidone, and to some degree even valproic acid or Depakote has also been associated with it. Is that taking it over a long period of time can have effect on bone, that it causes negative calcium balance, that your bone causes more likely to develop osteopenia or osteoporosis ultimately. This is more of a problem in women than men, which is in general the case for osteoporosis. Sometimes it is associated with, we don't understand exactly how long you have to take it, which women or which person is more likely to develop that. of what age you get exposed may have to do something, like when bone is forming in your teenage years. If you're already on those medication, maybe you start with the less bone mass to begin with, because most of our bone mass is built during our teenage years, and we just maintain it. If you don't build enough reserve then, by taking this medication, maybe you will be more prone to osteoporosis in future. Even if you have a bone mass enough, then if you take this medication over a long period of time, maybe that also affects your bone and makes you more prone to have osteoporosis. So we don't have enough information on all the new medications, but in general it is believed that newer generation of medication, because they don't affect this part of metabolism as much, are probably less likely or not likely at all to cause this problem. But we don't know that enough about those things yet.
And are there standard recommendations then in terms of vitamin D and calcium?
There is no standard recommendation regarding osteoporosis, but people, or especially women who are on this medication for a long period of time, say 10, 20 years, and they are getting into their middle-age years in their 40s and 50s, some docs do recommend to screen them for osteoporosis, at least get the test to see if they do have that problem. If they already have a problem to a degree that needs to be treated, then their medical doctors can start treating them with medication, which may be once a month type of therapy to build the bones back up.
Yes.
Okay. Other questions?
Yes, I was wondering, can puberty change? Can puberty increase seizures? My daughter is in puberty right now, and it seems like her seizures are different from what they were when she was younger.
That is definitely the case. There are certain type of seizures actually first present at the time of puberty or in late teenage years. Puberty can make things worse. There are certain type of seizures actually puberty makes it better, that you have seizures when you are young, but around the time of puberty those type of seizures go away. But in majority of the cases, puberty can make seizures worse, and similarly, in some women, menopause makes seizures worse. They may have more problem around menopause with the seizures getting worse. So that is definitely true. It may not be necessarily just the estrogen, progesterone type of hormone changes. It is much more to do with how the brain actually goes through the transformation with a variety of neurochemicals with changes at the time of puberty as well as at the time of menopause.
If you started your seizures when you began to menstruate, when you go through menopause, can you stop your seizures?
Not necessarily. Unfortunately, it doesn't work that way. As I said, it is not necessarily just estrogen and progesterone, because otherwise we can prescribe you estrogen and progesterone and fix somebody's seizures that way. But it is more than just estrogen and progesterone. It's more chemical changes within the brain which may be triggering things.
Because all my seizures come the week before I menstruate.
That's not unusual also. That's called catamenial pattern of seizures. And there are certain strategies sometimes we use for somebody has a very strong pattern like that. You can sometimes treat with the hormones like progesterone and may help to suppress the seizures. There's a medication called acetazolamide or Diamox, which is actually a water pill or diuretic, which can also be given to around the time when the seizures are likely to happen, and sometimes that also helps to reduce seizures. Sometimes you can strategically use benzodiazepine like Ativan and things just for a certain time during the cycle to see if you can prevent those seizures from coming on. So if somebody has a very strong pattern, then there are specific strategies to treat that may help to reduce number of overall seizures you get.
Any other questions?
How can you tell if you're taking anti-epileptic drugs and epileptic drugs? Which are which?
There is no epileptic drugs. It's all called anti-epileptic drugs.
So they're all called anti-epileptic. Thank you.
Nowadays, they recommend to change. Recently the report came out that not to call them anti-epileptic drugs, but call anti-seizure medication because they are not truly anti-epileptic. They just treat, or they just prevent seizures from coming on. They don't treat epilepsy. Epilepsy is a condition where seizure is one of the symptoms. And this medication works only on seizure aspect of things, not other aspect of condition. Like you have a mood effect and memory effect, these medications don't do anything to those. Those are part of your epilepsy, but no, these medications don't do anything to those.
That's primarily for seizure.
All the medications we call anti-epileptic actually works just for seizures, and they don't eliminate seizures completely. We just give you to prevent seizures from coming on. That is, these medications don't prevent seizures from coming they don't cure you from seizures. The only way we know and currently to cure somebody of seizures is that their seizures coming from small part of the brain and surgeon can go and take it out and then you can stop having seizures. Mm-hmm. That is only cure we have that medical people can provide. But medications are always just to prevent the next seizure from coming on. Yes. They never eliminate your underlying condition.
Okay.
Other questions? We have about 10 minutes left.
Is there any new drug studies coming out for new drugs?
Okay, there are. If you just look at it generally, there is always new drugs in development. The pharmaceutical industry is always looking for something. Are there any drug studies going on currently? Yes, there are. There are drugs at the just got approved by FDA. There is one called ritagabin or ezogabin, which was approved a couple of weeks ago, which is, I don't think, available in the market yet. I mean, it is available in market, but I don't think pharmacists have got the stock yet because I wrote a prescription was not filled because pharmacy can't get it.
And that was FDA approved just recently?
Yeah, it's called Potiga, trade name.
Yeah.
Or aceclidine is a generic name. Okay. There are a couple more which are being, I think, within the hand of FDA. There are, but obviously not available in market. There are clinical trials going on at our center. We are doing several clinical trials for medication, which some of them are available in market, but we are looking for a different indication, meaning they are approved for one type, and now we are trying to see if they work on another type. We are also looking at certain medications which are not available in market yet, and we are doing clinical trial on those. There is a drug which we are trying to see if we can develop a different way of delivering it, meaning by intranasal spray instead of giving by IV or by mouth. Those stop seizures from somebody who's having seizures. So there are always something or other going on. From other modality of treatment, there are certain devices which is being tested. One is what's called deep brain stimulation, where the electrodes are inserted into the brain in certain part of the brain, and you stimulate that part of the brain with the current, by controlling the electrical current and sending the signal to it by a small computer chip which is planted in somebody's body, and wire goes in the brain, and over time that can reduce or eliminate seizures. So that is being variety of different target location within the brain where these electrodes are inserted. So those trials are ongoing. There is also a trial ongoing for something called NeuroPace, where you implant the electrode on the brain surface where the seizures are coming from, and it also has a computer chip and software. It try to read your EEG, and if it detects a seizure, then it will actually shock the brain with a small current. You don't feel it. The person doesn't feel it, but it zaps the brain with a small amount of electricity, and it is like fighting fire with fire. It stops the seizures. So that is the way it's supposed to work. And that is also being tested in clinical trials. So there are a variety of different avenues. There are a variety of different understanding of how the brain, seizures and brain works. So people are trying to develop different kind of medication, looking at once we understand how the seizures work or in what particular way, we try to see if we can develop chemicals to affect that mechanism and see if we can help the seizures.
Go ahead. I'm sorry. Will that ever be available in like maybe an EpiPen type of deal? Because it gets a little difficult when somebody has a seizure and to, insert Diastat in public is a little, intrusive.
That's, I can imagine. That is what I was saying, that there are we are doing actually currently a trial of trying to see if we can develop something similar to Diastat, but given with a nose spray. So you can just spray in somebody's nose that medication. So you don't even have to inject somebody. That is available, I don't think it is available in the market, but they have developed what you are calling something like EpiPen to give midazolam or Versed, which is similar to Valium or Diastat medication. They have used that in one of the trial where they used EMS to deliver this medication to see if that works to stop seizures and help to stop seizures en route to the emergency room, called Rampart trial. And this was run by mainly emergency room medicine doctors. And they have used this type of a device to deliver the medication. And in their study results that it seems to work well, and it can be used by EMS personnel. The problem with that is that this medication, and that also that can make people very sleepy. So you have to be careful. You give them, then you need to monitor their breathing and stuff.
Does it have to be kept refrigerated?
Diastat, no.
No, the EpiPen.
I don't know because it is not available in market. I just know that they use that way in EMS trial with Rampart trial. I don't know whether the storage needs to be interfered. I doubt it. I don't think it is necessary, but I don't know for sure. Because it defeats the purpose then. If you're outside home, how are you going to take it?
Right. Is the intranasal spray also Versed or something else?
It is going to be Versed if they can show that it is effective.
And this Protega that you mentioned, what kind of seizures does that best work for?
It is approved currently for what we call partial seizure or localization-related epilepsy, meaning seizures are coming from one part of your brain. Mm-hmm. Majority of adult seizures are that type. And it is approved as an add-on therapy, meaning you can give in addition to one of the other medication you already take.
So you will continue taking your medicine plus that?
That is how most of the new drugs come out. Like the one came before that was Vimpat in that class, and that also is still approved as an add-on therapy. And many of the other medications are all approved as an add-on therapy. There is a couple of other medications which came which is specifically indicated for something called Lennox-Gastaut syndrome, which is very severe epilepsy. Usually people have mental retardation with it. In young, many times it starts in children and continues as an adult. And one is called Benzel. There is another one called Onfi, O-N-F-I. That is also available now in market.
And how do they compare with side effects with those?
Side effects of other seizure medications.
Vimpat. What did you say this new one was? O-N-F-I?
Onfi. Now, Onfi and Benzel are approved for Lennox-Gastaut syndrome, so it's not used in general population of seizure patients.
Right, but that's what my daughter has, Lennox-Gastaut.
So Benzel, no, it is tolerated well. Onfi is again a benzodiazepine, so it is something similar to Valium and Versed, but it has less side effects in form of sedation, and it works over a longer period of time, and patients don't get used to these drugs because Ativan or Valium works for a short period of time and then it stops working because the brain gets used to it. Mm-hmm. And it loses its effectiveness. On the other hand, Onfi or clobazam continues to work over a longer period of time, and it is not as sedating. So that is something useful It has been around in market, in world market for many, many years. It used to be, we used to write prescriptions mainly for children to go to Canada and bring it from there because Canada had it on market for many, many years.
So what, just as on a closing note, we spoke about some of the treatments on the horizon. What area of treatment or area of research, I guess, is most promising to you, or which gives you the most optimism that there'll be any kind of breakthrough in epilepsy treatment?
I think there are 2 or 3 ways to look at it. One is I think the computer technology is going to help us understand a lot and also help people to manage their lives better. So I'm sure simple things like your iPhone application, apps and stuff like that. Once people figure it out, how to control, how to help their lives when you have seizures and things like that. Even small things can be very helpful. It will be, obviously it will provide a lot more information to people because now people can pull on information quite easily. I think more and more emphasis is going to come up in providing that type of organized, better information online by various organizations like Epilepsy Foundation, and more standardized way of doing it probably will help patients. I think that is one thing I'm very helpful. It's a simple thing. It's not medical, but it will be very helpful for the patients to learn and manage things better.
Right. There are
I'm sure that this helps.
two different iPhone apps that are used for tracking or journaling your seizures. So
right there, I have seen those. Medication reminders.
Right. Exactly. So.
Once we will have more accountability and quality requirement for healthcare industry to provide, people will have more access about who is doing what, which centers and which programs are able to provide more comprehensive care, so they can access it much better or easier. I think that will also improve the care. And the medical front, obviously, as we understand how brain works better and better over time, we will develop better and better targeted treatment, and some of this targeted, maybe one of this targeted treatment will come out to be much more useful than what we have currently for seizures. Maybe we will be able to predict who will develop seizures or epilepsy after, say somebody has a head trauma or brain surgery and they are at risk of developing seizures. Maybe we can give medication to them for a short period of time after trauma and prevent them from developing epilepsy in future altogether.
Right.
Once we have that kind of understanding and that sort of a detail available, we will figure it out what medication, what can strategy be used to prevent epilepsy from even coming on. And then understanding how seizures work, we will have a variety of different mechanisms to go after how to prevent seizures from happening. That is, to some degree, is happening like Potiga, which came out. It's a potassium channel. It was designed to affect potassium channel. And they looked at the variety of different chemicals, variations of a compound, and ultimately found something which works. So more of a designer drugs which will come up. And from computer ways and implantation and surgical technique improvement also will help us to treat seizures with surgical management much better. We are already doing much better job than what we did 20 years ago, because the way with the neuronavigation or how the surgeons use computers in OR and all the imaging technology available there, it clearly will help. We will have other ways of looking at the brain with MRI and PET scan and maybe some other stuff to understand where the seizures are coming from, and maybe surgery will be improved. Our surgical outcome will be available to more patients. So there are a lot of things which would happen in the next 10, 15 years that would be impacting seizure, epilepsy field as a whole.
I have one quick question.
Go ahead.
How do they isolate where you're having the seizure at? Is it a generalized seizure or temporal or whatever? Is that done through an EEG, or how is that done?
Usually by EEG, but there are other tests which can assist in that. But primarily it is the EEG which helps us to figure that out.
Okay, thank you.
I also have another question. If you have a vagal nerve stimulator, My daughter's physiatrist asked, could she use electrical stimulation to exercise her muscles, or wouldn't you be able to use it with a vagal nerve stimulator?
I don't believe that should be a contraindication, but if that is the case, we should probably, we can check with the company, Cyberonics, which makes a vagal nerve stimulator, and they probably can give you a much more definitive. But just knowing how both of those work, I don't think unless we are very close, it shouldn't matter.
Okay.
If you are using it on a back or something, it shouldn't matter.
Mm-hmm.
Okay, very good. Well, thank you so much, Dr. Shah, for your time. And
thank you, Russ, and thank you, everybody.
And hopefully everyone else learned a lot. And next week we have Ask the Pediatric Epileptologist. So any parents on the line, it's another great opportunity to learn more about epilepsy and ask questions specifically related to childhood epilepsy. So thanks again, and we'll talk to you hopefully soon.
All right, Russ, take care. I'm going to hang up now.
Okay.
Thank you. Bye-bye.
Thank you, Russ.
Bye.
Bye.
Bye-bye.